everybody, welcome to my channel Rad by MS. So who am I? My name's Mathuri. I'm a consultant radiologist in the UK, and the main ethos of this channel is radiology education. And what I'd like to do today is talk about chest X-ray anatomy. This will be very useful for medical students and those of you who are about to take your Part 1 exams. Chest X-ray anatomy is a favourite, and if I was a betting person, I would bet that you would have a question on this in your exam. And remember, anatomy is really important to understand before we start interpreting our images. Okay, let's get started. So the first topic that we're going to start off with is the airways. So airways. So you can see on this radiograph here, the trachea is centrally located, and the trachea branches into the right and left main bronchus at the carina. Now, the right bronchus divides into the upper lobe bronchus and bronchus intermedius, and the bronchus intermedius further branches into the middle lobe and lower lobe bronchus. On the left-hand side, you've got the left main bronchus, which divides into the upper and lower lobe bronchus. Now, remember that the right main bronchus is shorter, and you can see that the bronchus intermedius is vertically orientated. So if you aspirate or inhale foreign body, this is the main reason that the most likely location that this will go to is the right lower lobe. On the left-hand side, the main bronchus is more longer and obliquely orientated. So let's move on to the lobes of the lungs itself. The important thing to appreciate is that on the frontal radiograph, the lower lobes extend quite superiorly to the level of T5 on the right and T4 on the left. So differentiating between pathology in the upper and lower lobes on the frontal radiograph is quite difficult unless we've got a lateral radiograph to help with that. So instead, what we can use for descriptive purposes of pathology is divide the radiograph into upper, middle, and lower zones. The other thing to appreciate on some chest X-rays is the horizontal fissure. This can be seen as a horizontal linear line that extends from the periphery to the hilum, and the horizontal fissure divides the upper lobe from the middle lobe on the right. Right, so next let's move on to the pleura. So we're going to talk about the costophrenic angle, where the diaphragm meets the inner chest wall laterally. It's a sharp, acute angle typically, and blunting of the angle can indicate a pleural effusion. And what's interesting to note is that it's been found that you need approximately 200 mils of pleural fluid before the costophrenic angle is blunted on a chest radiograph. So we go on to the diaphragm medially, called the cardiophrenic angle, where the pleura meets the heart. Now, pathology here can be due to abnormal lymph nodes, lymphadenopathy, or could be due to a pericardial cyst. Often, the the thing that you see on radiographs is a pericardial fat pad, which can cause blunting in this area. So, cardiophrenic and claustrophrenic angles. So, we have natural opening in the diaphragm, which allows vessels and other structures to enter the abdominal cavity from the chest. So we've got three openings. At T8, you have the inferior vena cava and branches of the right phrenic nerve exiting. At T10, you've got the esophagus, the vagus nerve, and esophageal vessels exiting. And finally, at T12, you've got the aorta, the thoracic duct, and a zygous vein. This is a frequent and favorite exam question. Okay, so next let's talk about the mediastinal borders and the hilum. So, starting off with the mediastinal borders on the right. So, the right lateral heart border is made up of the right atrium. Remember, the right ventricle is an anterior structure, so therefore does not contribute to the right heart border. As we extend superiorly, you will see the superior vena cava. And the junction between the right atrium and the superior vena cava is the atriocaval junction. And this is a useful location to know, as this is the ideal position where our central line should be located. Now, moving on to the left-hand side. So, the first structure that makes up the border on the left is subclavian artery, and if we extend inferiorly, we've got the next knuckle that we see is the aortic knuckle, or the arch of the aorta, and below that you've got the pulmonary trunk, and the border between the aortic knuckle and the pulmonary trunk is known as the AP window. Okay, so the AP window typically has a concave border. Convexity or convex border in this region could imply pathology. This could be due to lymphadenopathy, vascular abnormalities such as aneurysm, or nerve sheath tumors. So next, let's move on to look at the hilum. So the hilum is the root of the lungs, where you see fine anatomical structures such as the pulmonary vessels, the major bronchi, and lymph nodes. The thing to recognize is that the left hilum is commonly higher than the right. The hilar point is formed where the upper and lower lobe pulmonary vessels meet. And the hilum is a really important place to look for potential pathology. So when you're looking at a radiograph, look at the position, size, and density of the hilum. Next, we're going to move on to lines and stripes. It's important that we recognize these structures on a chest radiograph, as abnormalities in these lines and stripes can be valuable to recognize on a chest radiograph and will be useful to identify as we can further investigate this abnormality on ACT. I'm going to start off with lines. So usually they're about, if you do see them, about 1 millimeter in width, and they are caused because you've got air outlined by, or tissue rather, outlined by air on either side. And they typically represent pleural covered structures within the middle and superior mediastinum. So you've got the anterior and posterior junctional lines. So the posterior junctional line is located more superiorly compared to the anterior junctional line. Next, we're going to move on to the stripes. Typically, these are more thicker lines and are seen when more thicker anatomical structures are outlined by air. So you've got the paratracheal stripe on either side, so the right and left paratracheal stripe. Thirdly, we've got another group of lines that is important to recognize on a chest radiograph are lines and stripes where solid structure border air. So you've got the right and left paraspinal line, the aortopulmonary stripe, and the esophagoesophageal recess. So recognizing this is very important because this can be a subtle indication of pathology on chest radiographs, which will. Other things to remember is the extent of the lungs is not just a lucent area on the chest radiograph. In fact, medially, the lungs extend to the posterior junctional line and extending inferiorly, with the esophagoesophageal recess being the border and extend below the diaphragm. So it is important to look at these areas when we're reviewing a chest radiograph, because pathology can be missed if you don't. That's part 1 of chest X-ray anatomy. Part 2 coming up in the next couple of days. If you like this content, please remember to like, share and subscribe. It's free of cost.